Thank you to everybody of being with us. This is a new webinar from the International Society of Gynecological Endocrinology, and I would like to thank Abbott for the support in the organization of this webinar and the simultaneous translation to so many languages. As you know, the International Society of Gynecological Endocrinology have its own conference next year in 2024 in May in Florence, and we decide to support our society by a series of webinars in that meantime. Today, we will speak about a very important topic, which is that not all progestogens are the same. And mostly we will speak about the relevance of progestogens in miscarriage. We will have two speakers. I will introduce first Professor Howard Carp and later Professor Petra Stute. And I will introduce Professor Petra Stute when she will make her presentation. We start now with Professor Howard Carp. Howard will speak about of the progestogens activity. Professor Howard Carp is Professor of Gynecology in the Tel Aviv University and Honorary Clinical Professor at the University of Nicosia in Cyprus. He has a special interest in recurrent miscarriage and pregnancy loss. Professor Carp has published over 80 original articles, 33 review articles, 13 book chapters, and has been invited to lecture in many parts of the world. He has edited 4 books: Recurrent Pregnancy Loss, Causes, Controversies and Treatment, The Infertility Manual, Principles and Practice of Assisted Reproductive Technology and Progestogens in Obstetric and Gynecological Practice. Howard, you have now the microphone. I remind to everybody that after presentation, I will introduce Professor Stute, and then we will have the question and answer. Please write your question in question and answer, and I will read the question directly at the end of both presentations to Professor Carp and to Professor Stute. When you make your question, please indicate also if one of the speakers or both of them are asked to answer to your question. And now, Howard, you have the microphone and you can share your slides.
Andrea, thank you so much for your introduction. My dear colleagues, I have been asked to speak to you today about the efficacy and safety of progestogens when we talk about miscarriage. And what I'm going to do is to speak about the evidence of efficacy, the confounders which we see in miscarriage, which may prevent us drawing relevant conclusions, what we should strive for, and the safety of progestogens. As for the first 3 of those, where we look at the evidence, the confounders, and what should we strive for, we will ask about the clinical role of progestogens, and the safety, we will speak about each progesterone separately, because the title is that not all progestogens are the same. When we talk about the confounders in miscarriage, then of course we have to look at genetic aberrations in the embryo, which can confound our results when we look at progestogens, and also malformations in the embryo. For evidence of efficacy, of course, we need evidence which come from trials and from collections of trials put together in meta-analyses. I shall speak about both threatened and recurrent miscarriage. First of all, when we speak about progestogens in threatened miscarriage, there is a very well-known meta-analysis by Lee, which went out about 2 years ago. And what they did was that they looked at oral progestogens in threatened miscarriage and micronized vaginal progesterone in threatened miscarriage. Now, as you can see, when we look at oral progestogen, when I speak about progestogen, by the way, a progestogen is anything which will trigger the progesterone receptor. If we look at oral progestogens, there's work by Evans-Jold, Omar, Pandian, 1, 2, 3, 4, 5, 5 papers in the literature. And when you have a look, you can see that oral progestogen was shown to be statistically significant in reducing the number of threatened miscarriages which developed into miscarriage. Odds ratio 0.58, which if you look at the odds ratio, if you look at the confidence intervals, are significant. When you look at vaginal progesterone, 1, 2, 3, 4, 5 studies, you will find that even though there is a trend, 0.73, in reducing the number of threatened miscarriages developing into miscarriage, that in fact is not statistically significant when you look at the odds ratio. Now, if you put all of those papers together, take all of the progestogens, then there is statistical significance. What did Lee say in his conclusions? Progestogens may benefit live births and miscarriage rates for threatened miscarriage, but the benefits appear to be confined to the use of oral progestogen, and no statistically significant improvements were seen with micronized vaginal progesterone. Now, there is one problem in this meta-analysis, and that is papers number 1, 2, 3, and 4 of the oral progestogens, in fact, looked at dydrogesterone. Turgel's study, which is highlighted here in purple, actually looks at micronized progesterone when administered orally. So if now we update that meta-analysis of Lee and add on some of our work in one of our meta-analyses from 2015, and when we exclude Turgel, because he used micronized progesterone, but include Chan's study, which came out in 2021 after Lee put his meta-analysis together, we find again that dydrogesterone significantly reduced the number of threatened miscarriages ending as miscarriage. If we look at the micronized vaginal progesterone, and I have not included Turgel here because we're talking about micronized vaginal progesterone, not oral, we have the same result, which was not statistically significant. That's in threatened miscarriage. One paper I want to point out is the paper of Kumasauri in 2019. In this paper, this was the largest series. You can see 2,079 patients, 2,074 patients in the control group, way above the small series which went into the meta-analyses. We find that this paper, which went out in the New England Journal of Medicine by Kumasauri, was a double-blind, placebo-controlled, randomized trial investigating whether micronized vaginal progesterone increases the live birth rate in women with recurrent miscarriage. As I said a moment ago, over 2,000 patients in each arm of the trial. And in a intention to treat meta-analysis, there was a 3% difference, 75% live births after micronized vaginal, 72% in the placebo arm, just touched on statistical significance, absolute difference 3%. Now, when something has a confidence interval from 1, you can argue whether that's significant or not. It's just touching on significance. Well, one particular form of threatened miscarriage is the retroplacental hematoma. Here we have an ultrasound scan showing the the pregnancy sac, the embryo, and this subchorionic bleed around it. Now, Pelinescu has done a study which was non-randomized, comparative cohort study of 100 women with threatened miscarriage and a viral embryo and a retroplacental hematoma who received dydrogesterone in a relatively large dose of 40 milligrams. There were 93 live births and 7 miscarriages. That's 93%. In the micronized progesterone group, there were 125 women, 81% live births. That leaves a relative risk of 2.04 in favor of dydrogesterone. Okay. If you look at the favorable pregnancy outcome as compared to miscarriage for dydrogesterone and for micronized progesterone, you can see that the difference between the two is much greater in the dydrogesterone group than in the micronized progesterone group. So here in a retroplacental hematoma, there also seems to be a greater advantage to dydrogesterone than to micronized vaginal progesterone. Move now from threatened miscarriage to recurrent miscarriage. Saccone's meta-analysis, 2015, in which we see a number of papers that have looked at the effect of using a progestogen threatened miscarriage. This is the meta-analysis. Again, Kumasawari's paper looked at micronized vaginal progesterone, and as you can see, there is no significant difference. There are 3 papers that looked at dydrogesterone. One of them, MacDonald, showed no difference. Another 2 did show a difference. Okay, so we can see that the only papers that were clearly significant were these 2 by El-Zibte and Kumar. Overall, there was a statistically significant difference. Now, let's have a look at Kumasawari's paper slightly more closely. But before we do that, this is our own meta-analysis on dydrogesterone, published in 2015, in which we looked at 3 papers which showed that dydrogesterone also had a significant effect in reducing the number of subsequent miscarriages in women with 3 or more previous miscarriages. In fact, the miscarriage rate went down from 23% in the control group to 10% in the dydrogesterone group. Statistically significant, odds ratio 0.29. So let's come back to the paper by Kumasawari on recurrent miscarriage using micronized vaginal progesterone, randomized trial. It went out in the New England Journal of Medicine, 2015, I think it was. Okay, double-blind, placebo-controlled, randomized trial. 404 women treated, 432 received placebo. In an intention to treat analysis, there were 65.8% live births after progesterone versus 63% in the placebo group. Relative risk 1.04, and this figure was not statistically significant. They called this trial the PROMISE trial. Now, PROMISE in English, well, you all know what PROMISE means, and I'm sure that all of the translators have translated it accurately, but it is also a play on words, PROMIS, progesterone in miscarriage. Unfortunately, there wasn't any promise in the PROMISE trial. Now, why do progestogens not always show their effect? Because there can be confounding factors. What do I mean by confounding factors? We all know that if you have a high alcohol diet, it is said that there's an increased risk of coronary heart disease. And if you have low alcohol consumption, you should have less coronary heart disease. However, if your low alcohol consumption consists of Coca-Cola, milk, and other fizzy drinks, you will not see that decrease in coronary heart disease. Your results will have been confounded, and you will think that a high alcohol diet really has no effect on coronary heart disease. Well, the problem is, if we go back to Saccone's meta-analysis for recurrent miscarriage, we find that there was a failure rate of 32%, in which the progestogen did not manage to prevent miscarriage. And that could be due to confounding factors such as embryonic aneuploidy and structural malformations in the embryo. Embryonic aneuploidy, here you can see a CGH chip. Here you can see the results showing a spike at chromosome 16, indicating chromosome 16 trisomy. Now, let me just say that chromosome 16 trisomy is incompatible with life. There has never been an infant born alive with 16 trisomy. It is absolutely fatal. Well, chromosomal aberrations account for 44% of recurrent miscarriages. Remember, it's 60 to 70% in sporadic miscarriages. The relative incidence decreases with the number of miscarriages. That means that the patient with 2 miscarriages is more likely to have a chromosomally abnormal or aneuploid embryo than the patient with 10 miscarriages. The incidence increases with maternal age, just as the incidence of Down syndrome increases with maternal age. The most common aberrations found in miscarriage are trisomies 16, 21, 18, triploidy, and XO. 16 is incompatible with life. 21 and 18 may be born alive with Down syndrome or with Edwards syndrome, but most of them will terminate in miscarriage. Triploid and XO are always incompatible with life. The only XOs that can survive are those that are mosaic, but when all the cells are XO, that is totally incompatible with life. Congenital malformations in the embryo. Now look at this upper picture. It is a sonogram. All you can see on this sonogram is a missed abortion. If you look at the lower picture, you can see, which is an embryoscopic picture, you can see the head of the embryo, the hand, and can you see that this whole neural tube is completely open in one huge encephalous seal? Well, embryoscopy is an advanced technique which is not usually available. I am grateful to Tom Philip of Vienna for this picture in the lower section, because he has also described that embryoscopy has shown developmental defects in 200 of 230 missed abortions: anencephaly, encephalocele, spina bifida, syndactyly, pseudosyndactyly, etc. And as I've said, embryoscopy is an advanced technique, so many of us miss these structural anomalies. And what's more is that many of these structural anomalies are eukaryotypic. They're euploid. So what should we strive for? Obviously, we need evidence-based trials to answer if treatment is appropriate for the majority of patients. However, evidence-based trials take no account of subgroups. They will only say if a treatment is effective in the majority of patients. Trials should try to exclude confounding factors, but often do not. When we have analyses for subgroups and exclusion of confounding factors, treatment can then be administered on a personalized basis rather than the evidence from a large group of heterogeneous patients. We must also try to find a biomarker indicating the need for progesterone supplementation. Now, as for embryonic aneuploidy, if we try to exclude it, as I said, it's 44% of recurrent miscarriages, 60 to 70% of sporadic miscarriages, but no trial has assessed progestogens, which is limited to patients losing euploid embryos. Now, even if the abortus has not been genetically assessed, you can perform a CGH meta-analysis, that means complete chromosomal hybridization, on paraffin blocks or histological slides of previous miscarriages. Now, as I say, that has never been done with progestogens. However, with other treatment modalities for recurrent miscarriage, that has been done. For example, Scarpellini and Spraccia, two good friends of mine, published a paper back in 2009 on patients with 5 miscarriages losing at least 1 euploid embryo. Odds ratio 5.1, and this was for using filgrastim, GCSF. Confidence intervals statistically significant. However, Zafardus came along and said, why use patients with 5 miscarriages? Let's use the more common definition of 2 miscarriages. We want to see if it's good for everyone, not only when you've excluded euploid embryos. And using those very wide criteria, they managed to reduce these highly statistically significant results down into insignificance. So, as I say, when you choose your population for losing euploid embryos, you could get different results. Immunoglobulin is another treatment modality which has been very, very controversial. Only recently, in this last year, has this paper come out from Yamada of Japan using intravenous immunoglobulin in women with recurrent miscarriage, meaning 4 or more miscarriages, 4 or more, using immunoglobulin in patients who had lost at least 1 euploid embryo. So they had excluded to an extent the aneuploid embryos. And let's have a look. Ongoing pregnancies, 62% with IVIG, compared to 34% in the placebo group. Odds ratio 3.07. And if we look at live births, 58% live births compared to 34.7%. Odds ratio 2.6, showing the importance of choosing your patients correctly and excluding confounding factors. Is there a biomarker indicating the need for progesterone supplementation? This is Philip Corey's work showing that LH is secreted in pulses, and as a response, progesterone is secreted in pulses. The problem is when you look at serum progesterone levels, you may draw your blood for progesterone at a pulse peak or pulse nadir, and they can vary tenfold. Now, there are works that have tried to look at progesterone levels with various degrees of success. However, they're not that reliable a sign of progesterone lack. There's another kid on the block, PIBF, the progesterone-induced blocking factor. Produced by T lymphocytes when treated with progesterone, blocks natural killer cell cytotoxic activity. It increases the production of the Th2, the anti-inflammatory cytokines. Its production rises with trophoblast invasion. So PIBF, progesterone-induced blocking factor, may be related to the abortive effects of progesterone. In this graph, which I'm grateful to Petra Ark, you can see that higher PIBF levels predicted a higher ongoing pregnancy rate. However, it is not available for generalized clinical use. The last subject I really want to talk about is safety. I don't know how many of you remember the series The Simpsons, when Homer Simpson was working at a biological plant and they managed to get this three-eyed fish. Well, progesterone was considered by the United States Food and Drug Administration as being category X until it was used for luteal support in IVF. Why was that? Because they had seen 81 cases of masculinization of female external genitalia with one particular progestogen called norethisterone from the 1950s and early 1960s when used to prevent miscarriage. In 1989, after determining that progestogens did not cause birth defects, the FDA required a warning on progestogen which was approved for use in pregnancy, saying that there were reports of increased risk of hyperspadias in male fetuses, an anti-androgenic response, a mild virilization of the external genitalia of female fetuses, a proandrogenic response, depending on which progestogen is used, using norethisterone as the proandrogenic progestogen, which is not used in pregnancy today, and micronized progesterone as the anti-androgenic progestogen. And Carmichael in 2005 reported a risk of hyperspadias of 3.07. Sorry, 3.7. There have been no reported cases of hyperspadias with dydrogesterone. Now, let's have a look at some of the side effects and problems of using progestogens. Micronized progesterone, if you take it orally, is degraded in the liver, and there are extreme variations in plasma concentrations. Past the first trimester, it might cause cholecystasis. That is there in the UK label. Nausea, headache, and sleeplessness. It might interfere with driving ability. Vaginal administration avoids the hepatic metabolism. There's rapid absorption, bioavailability, and local endometrial effects. However, there are problems with patient compliance. The micronized progesterone can be uncomfortable if there's bleeding or discharge, and it may be washed out if bleeding is severe. Irritation, discharge, and allergies in 10% of patients. Some of those allergies we have seen occasionally, which show as effects in the skin, urticaria, rashes, showing a sensitivity to progesterone. And of course, there is the question about hyperspadias. And remember, if a woman uses micronized vaginal progesterone, she needs to find a clean room, lie down for 20 minutes every time she inserts the progesterone 3 times a day, and if there's discharge, micronized progesterone may be washed out. Now, to lie down 20 minutes 3 times a day, I know women who want a baby will do anything. However, it is a severe strain on their lifestyle. Dydrogesterone, on the other hand, has good bioavailability. There's no inhibition of progesterone formation in the placenta. There's no androgenic or anti-androgenic effect on the fetus. It's not degraded in the liver, it's metabolized in the liver, but the metabolite is also progestogenically active. Minimal side effects, not washed out by bleeding or discharge, and of course, the patient only has to take a tablet and there is no disruption to daily life. Dydrogesterone has been used for over 40 years in more than 90 countries. It's been estimated that between 1977 and 2005, approximately 10 million women have been treated and more than 10 million fetuses exposed. So far, there's no evidence of a causal link between dydrogesterone in pregnancy and birth defects. Recently, there has been one report which was later withdrawn due to doubts whether the experiment had actually been done. And there is now a paper by Klatinik, 2022, that looked at the various studies of dydrogesterone to look at side effects. 1, 2, 3, 4, 5 studies. And as you can see, there was absolutely no effect in dydrogesterone causing any form of anomalies. So, should we use progestogen? Guidelines. European Progestin Club. Yes, dydrogesterone. The German, Austrian, and Swiss gynecological societies. Synthetic but not natural progesterone can be administered in the first trimester to prevent miscarriage. Eschri, in the 2017 guideline, dydrogesterone has an evidence base and can be prescribed in early pregnancy for women with recurrent miscarriage. Vaginal progesterone does not improve live birth rates. However, now I'm confused. Why am I confused? Because Deval, about 2 years ago, brought out a new meta-analysis in the Cochrane database. And he included certain trials. Sorry, I should say they, it was Deval et al. The PROMISE trial, the PRISM trial, Gerhardt's trial, and excluded other trials. No mention of Ehrenström Misto's trial. They excluded Elzibtis trial, and then they sent questionnaires to the various authors, to Omar, Pandian, Kumar, Paliano, Alomadi, Yassi, Reintiers, and if they didn't get an answer to their questionnaire, they excluded the trial from their meta-analysis. Well, I ask you, is failure to answer a questionnaire a cause for exclusion? Some of those authors might be dead by now. I don't know. So only a few trials were included. And let me put it this way. The Cochrane database in Wahhabi's meta-analysis of 2018 looked at all of these papers and said progestogens probably reduce the risk of miscarriage in threatened miscarriage. Treatment with oral progesterone reduces the miscarriage rate. Micronized vaginal progesterone has little or no effect. Now they've done a complete about-face in Deval's meta-analysis. Because of all the papers here, only one has now been included for the dydrogesterone, and have said in threatened miscarriage, there's no improvement in the live birth rate with micronized vaginal. In threatened miscarriage, with no previous miscarriages, no effect. But in threatened miscarriage with previous miscarriages, micronized vaginal increases the live birth rate. Now, I don't know, maybe somebody can explain to me how something which is evidence in 2018 can be non-evidence in 2021. I don't really understand it. Well, I'm puzzled. What are we supposed to do? NICE and Duval recommend micronized vaginal progesterone for threatened miscarriage with previous miscarriages, but micronized progesterone has not been recommended for recurrent miscarriage or threatened miscarriage, as the PROMISE and PRISM trials are negative. Dydrogesterone has been recommended for threatened and recurrent miscarriage independently by numerous international organizations as a solid evidence base. Dydrogesterone has not been analyzed for patients with threatened and previous miscarriages. And in the real world, you try and tell a patient with 3 miscarriages to only be treated when she starts to bleed. Try and tell a patient with threatened miscarriage that she should only be treated if she's previously miscarried. I put it to you that it is not possible, and that is not being fair to your patient. So thank you for listening on this webinar. And the take-home message is that the results of studies so far published may be confounded by fetal factors. Progestogens prevent miscarriage of a viable embryo, not of a non-viable embryo. Trials must be much more specific in patient selection. A biomarker indicating the need for progestogen is urgently required. At present, dydrogesterone seems to have more evidence than micronized vaginal progesterone, except possibly when threatened miscarriage occurs in a patient with previous recurrent miscarriages. Do progestogens work? Yes, but they're not a panacea. Thank you very, very much. Thank you, Professor Genazzani, for inviting me to speak to you. And thanks to the Abbott Company for having made this webinar possible. Thank you.
Thank you. Thank you. Thank you very much, Professor Carp, for your extensive lecture and presentation of on this fantastic topic, which is the effect of progestogen. I would like also now to go on and to ask to all people to send their question for the 2 speakers. My pleasure is now to introduce Professor Petra Stute. Petra, she is a professor and she's board certified for obstetrics gynecology, gynecological endocrinology, and also reproductive medicine. She's head of gynecological endocrinology and menopause center at University of Bern, where she's also associate professor. She's the past president of the Swiss Society of Gynecological Endocrinology and Menopause, and she's also an EMAS board member. She has a fantastic production that you can see in PubMed of scientific paper, and she's an expert in that area. And then she will cover the topic of that not all progesterone are the same, going on specific case studies. Thank you very much, Petra. You have the microphone and you can go.
Thank you very much, Andrea, for the introduction. And I'm glad you already mentioned several times that my focus is gynecological endocrinology and menopause. So I'm not addressing the topic miscarriages. So this is my conflict of interest. And for me, it was important to already say at this time that some of the recommendations are quite my personal experience. So it's like a level of evidence 5 if I did not find enough scientific evidence for what I thought the patient could receive. So we have several progestogens available for our patients. As you all know, we have nortestosterone derivatives, we have progesterone derivatives and spirulactone derivatives. And we've already heard a lot about dydrogesterone and micronized progesterone. But in some cases, all the other progestogens are also important for our treatment options. So I would like to start with my two protagonists that you probably all know. So on the left-hand side, we have Wilmer, and on the right-hand side, we have Betty. And I would like to start with their stories 5 years ago. So at this point, Wilmer was 40 years old and her menstrual cycle was already a little bit irregular. So her menstruation came every 17 to 32 days, and it lasted for 5 to 15 days, and there was some kind of trend for heavy menstrual bleeding. She has a comorbidity, which was or is migraine without aura. She's a non-smoking woman and she has a normal body weight. And as a medication, she only takes analgesics from time to time because of her migraine. Her family history reveals that she has a father with heart disease, and the reason for her consultation at this point was abnormal uterine bleeding. So now we turn to Betty. So she was 38 years old at this time, and she had a regular menstrual cycle. She didn't have any comorbidities. She was also non-smoking and had a normal body weight. She didn't take any medication, and her mother was diagnosed with breast cancer. And her reason for consultation was contraception. Okay, so what I do first when a woman comes to my clinic is I would like to know in which reproductive stage she is in. So I always use this straw plus 10 workshop chart. And as we can see now, Betty is in her late reproductive stage, and Wilmer is during her early menopausal transition because her menstrual cycles have changed for more than 7 days in comparison to when she was younger. So let's start with Betty. So she needs contraception and she's in her late reproductive stage. So if we have a look at the WHO guideline from 2015, we can read that age 38 in general is not a contraindication for combined oral contraceptives. However, we all know that COC or combined oral contraceptive starters have an increased venous thromboembolism risk during the first month of use. So this is, for example, the reason why we in Switzerland, we recommend to women that are older than 35 years old, when they think about starting a contraception, that in those women, we recommend progestin only or a non-hormonal contraceptive. So what can we offer to Betty now? So we can either say, well, let's use an intrauterine device, either with levonorgestrel or a copper IUD, or we could also offer a progestin-only pill, which either with either desogestrel or drospirenone, or we could also offer Implanon as an implant. However, if you still think about using a combined oral contraceptive, then it's probably best to use one with the lowest venous thromboembolism risk. So we could either use, for example, a combination of ethinyl estradiol and levonorgestrel, or we could use a combination of estradiol valerate combined with Dionogest, that's Clyra, or a combination of estradiol with Numac, which would be Zoeli, or also Drovelis, which is the combination of estetrol and drospirenone. And of course, sterilization and vasectomy would also be an option. So let's look at Wilmer. So she's coming because of an abnormal uterine bleeding in the early menopausal transition. Of course, we have to do first a gynecological examination, including a transvaginal ultrasound. And in this case, everything is fine. Also, the vital parameters are fine. And we have to consider that if the abnormal uterine bleeding persists, that we have to consider endometrial biopsy. So the lab workup should include a pregnancy test. In this case, Wilmer is not pregnant, but she's diagnosed with iron deficiency without anemia because of this trend to heavy menstrual bleeding. So again, the question is, what could we offer? So first of all, it's probably a good idea to give her some oral iron because of the iron deficiency. But at the same time, we want to do something which stabilizes her menstrual cycle or even induces amenorrhea. So the first line treatment in this case would be a levonorgestrel intrauterine device, which also has an indication for heavy menstrual bleeding. But if, for example, the patient does not want to use an intrauterine device, we could also offer progestins only. And there are several, but not too many studies out there that, for example, have used dydrogesterone 10 to 20 milligram per day on cycle day 11 until 25, or NITA, which is etesterone acetate, 5 to 10 milligram per day on cycle day 4 until 26, or very easy, just continuously. However, if you think about a low dose combined treatment, then you could choose, for example, low dose sequential estrogen progestogen HRT, which could be oral estradiol 1 milligram per day, combined with sequential dydrogesterone 10 milligram per day. And this would be, for example, the product Femostone 110. If for some reason you think about using a combined oral contraception, because maybe Wilma is also interested in having a contraception, then it's better to choose a combined oral contraceptive with bioidentical estrogens because of her age and because her comorbidity, which is migraine without aura. So again, in this situation, I would choose either Clyra or Zoeli or Drovelis. And of course, if bleeding is the only issue in this patient, we could also think about performing surgery, like doing an endometrial resection. Now, a few years later, which is now, the two ladies come back for consultation. So now Wilma is 40 years old. Her cycle has changed again. So now her menstruation comes every 4 months. And that's one reason why she's coming. Her migraine without aura is progressive. She is still doing fine, so no other comorbidities. She's still a normal weight woman. And the reason why she's coming now is menopausal symptoms. So Betty is now 43 years old. Her cycle has also changed. So now the menstruation is every 35 to 50 days, and she's still taking not any medication. And the reason for the consultation today is also menopausal symptoms. So let's go back to our STRO plus 10 chart to find out in which reproductive stage Wilma and Betty are in now. And you very quickly will know that Betty is now in the early menopausal transition and Wilma is now in the late menopausal transition because she has intervals between 2 menstruations of more than 2 months. And that's the definition of late menopausal transition. Okay, and now let's have a look at the wish list of those two women. So both of them say, well, I would like to have less hot flashes. I would like to have an improved mood, and I would like to sleep better. And Wilma also says, I would like to have less migraines. And Betty is saying, I don't want to take any chemistry. Okay, let's think about what we could offer to these two women. And this is the treatment options we have for menopausal women. Well, we could just say we do just nothing. We could just observe and see if the symptoms are getting better. And if it's not getting better, we can still try any of the other treatment options. Or we say, let's try some alternative therapy, which comprises, for example, herbal therapy or also acupuncture. Or in some cases, we could also suggest non-hormonal pharmacotherapy, like antidepressants, anticonvulsants, or antihypertensives. Or we say, let's take the first-line treatment internationally for the climacteric syndrome, which would be HRT, hormone replacement therapy. And no surprise, because it's the first-line therapy worldwide, the increasing efficacy is mirrored by the arrow on the downside of the slide. So let's focus a little bit more on HRT. So in general, we have estrogens, we have progestogens, we have tibolone, and we have something called TSEC. And let's have a closer look at these treatment options. So in general, we have estrogens, progestogens, tibolone, a TSEC, which is a combination of conjugated equine estrogens and the SERM basidoxephin, and we have androgens. However, androgens are not approved in most countries, but the rest of the products are approved in most countries. And what is interesting at this point here is that only estrogens and progestogens are actually approved for peri- and postmenopausal women, while, for example, tibolone and also the TSEC is officially only approved for postmenopausal women. So this means, as our two women, Betty and Wilmer, they are still during their menopausal transition. The first thought is to use something out of estrogens in combination with a progestogen, because both women still have an intact uterus. So now we have to decide which kind of HRT we would like to use. So the focus will be, of course, on a systematic HRT, so something which will work everywhere. So we can either choose between a pill, a patch, a gel, a spray, or in some countries also we have implants or injections available. If there are only vaginal symptoms, then of course we can provide vaginal estrogens or vaginal DHEA. Or, as we've already talked about, we could also provide a levonorgestrel intrauterine device with only a systemic or weekly systemic effect. So we still have to make up some more thoughts before we can prescribe something, because now we have to decide, first of all, how high the dosage of estrogens should be, and secondly, how we want to apply the estrogens. So do we want to apply them orally, or do we want to apply them transdermally? And if, for example, like in our cases, the hot flushes or any other menopausal symptoms are not so severe, it's most of the time enough to start with a low dose or even ultra low dose estrogen therapy. Why is it important to think about the estrogen dosage? Because if a woman still has an intact uterus, we have also to choose a progestogen. And then the next question will be, what
we have some audio.
But let's have a look first, what kind of progestogens are usually chosen for hormone replacement therapy in menopausal women. So you can see in the first lines, we have micronized progesterone, we have dydrogesterone, but we also have the opportunity to provide MPA, so medroxyprogesterone acetate in some countries. Levonorgestrel is mainly available as an intrauterine device, and the progestogen NETA is available orally as well as also in patches. And you can see that all of these progestogens, they bind to the progesterone receptor. All of them are anti-estrogenic, but then some of them are androgenic, like for example, NETA, while others are anti-androgenic, like for example, progesterone. And there's a special thing about progesterone, because as you all know, if you take progesterone orally, it's metabolized to allopregnanolone. And allopregnanolone binds to the GABA A receptors in our brain. And that's why so many of us like progesterone, because this allopregnanolone makes or supports our sleep and also our mood. But let's come back to the question, how high or low can the progestogen dosage be in depending on the estrogen dosage we choose. And this table only refers to oral progestogen dosages for endometrium protection. And you can see on the left side the different progestogens that are available. And then in the second column, you can see the dosage that is necessary every day if you use a sequential treatment regimen. And on the right side, you can see the dosage that is necessary if you choose a continuously combined regimen. And you still see a range. So for example, for micronized progesterone, if you apply it sequentially, you can see the range between 200 and 300 milligram. And if you use it continuously combined with an estrogen, you see the range between 100 and 200 milligram. So now you may wonder, so why are these ranges? And the answer is, if, for example, you use a low dose or even an ultra low dose estrogen dosage, you can also stick to a lower dose of the progestogen. However, if you use a higher estrogen dosage, or if you have a risk factor for endometrial cancer, for example, like obesity, then it's better to choose a higher dose of the respective progestogen. Then just a few remarks about HRT counseling in general in healthy women below the age of 60. So we have quite a long list on the pro side. Of course, the menopausal symptoms will be reduced. It's positive for bone, for heart, for brain, also for diabetes prevention. So there are a lot of pros, but also there are some con sides. And the con side that is most of the time in the focus is breast cancer risk. But it's very important to have a closer look of what kind of HRT we are talking about. So breast cancer risk is only increased if you combine estrogens with progestogens and use it for more than 5.5 years. So this risk increase does not apply to estrogens alone, does not apply to tibolone, and as far as we know, it does also not apply to TSEC. The second focus, if we talk about cons in HRT, is the venous thromboembolism risk and stroke risk. However, again, it's important to have a closer look if it really has an impact or if it matters what kind of hormones you are taking. And the answer is yes, it's important. So VTE and stroke risk are only increased if you apply estrogens orally. Okay, we come back to our two patients. So as we have already said, Betty has menopausal symptoms. She's in the early menopausal transition, but she doesn't want to take any hormones. So she decides for a herbal therapy, like, for example, black cohosh. And after 2 to 4 weeks, that's usually the time when I have a telephone consultation with a patient. In this case, the symptoms are still unchanged, but she doesn't have any side effects. She wants to continue. And after 3 months, when we see each other back, she says that her hot flushes have been reduced and mood and sleep is better. So she wants to continue. But what about Wilma? So Wilma also has menopausal symptoms. She's in the late menopausal transition. She does want to take HRT, and she is in perimenopause. And we know that migraine attacks increase during perimenopause due to the higher estrogen fluctuations. So what can we think about in this kind of situation? So the good thing is she does have migraine without aura, so which means that we can give her some kind of estrogens, but it should be a low dose estrogen treatment. And now, because she still has a uterus, we have to give her also some progestogens for endometrial protection. So we could either offer her a levonorgestrel intrauterine device, with is in-label or off-label in some countries, depending where you are living. Or you could combine the low-dose transdermal estrogens with oral micronized progesterone, 100 to 200 milligrams per day. Or you could also say, I would like to suppress inhibition because I want to reduce the estrogen fluctuations as much as possible. And this is why you could offer a desogestrel or a drospirenone progestin only pill. And then off-label, you could also combine it with a low-dose transdermal estrogen. So now you remember that Wilmer has a father with heart disease. So she is very interested in the association of HRT and cardiovascular risk. Especially she's interested in the association between bioidentical HRT and cardiovascular risk. And in order to find out if there is some kind of concern we have to have, one of my doctoral students performed a systematic review that was published last year. So this was a systematic review on the impact of estrogens combined with micronized progesterone on venous thromboembolism, stroke, and heart attack risk. So we could include 12 studies. These were different study designs, and no surprise, hormone dosages and regimens were quite heterogeneous. And cardiovascular events were either registered as a primary endpoint or as an adverse event in those studies. So to make the whole story very short, so we had overall 4 studies that used cardiovascular disease as a primary endpoint. So this was the E3N study from France, the ESTER study, the MIBI study, and the French National Insurance System study. And in 3 out of 4 studies, the venous thromboembolism was used as a primary endpoint, and 1 study used stroke risk as a primary endpoint, but there was no study that used heart attack as a primary endpoint. So what all these 4 studies found out was that if you combine estrogens with a metabolically neutral progestogen like micronized progesterone or dihydrogesterone, then there's no increased risk of VTE or stroke found. So this means if we only focus on CVD as a primary endpoint, then the combination of estrogens with progesterone or dihydrogesterone seems to be very safe. Then also we analyzed those studies that had used CVD, cardiovascular events, as an adverse event, and we only included on this slide here the placebo-controlled trial. And you can see we have overall 4 placebo-controlled randomized trials, and with different durations, 3 years, 4 years, 5 years, 1 year. And again, of course, there were several severe adverse events. However, there were no significant group differences between the active treatment groups and the placebo group. So the conclusion of this review was that micronized progesterone and also dihydrogesterone as a combination partner in HRT has a neutral effect on the vessel symptom. Now, 3 years later, so Betty is happy. No, sorry, Wilma. So Wilma is now postmenopausal. She's using a continuously combined low-dose transdermal estrogen, and she combines it with oral micronized progesterone. She has less migraine effects, so she's happy. However, now Betty has changed completely. Now she's in the late menopausal transition, and she has very severe hot flushes. So black cohosh is not enough anymore, and she's actually considering HRT, but she is afraid because of her mother who had breast cancer. So let's have a look what the North American Menopause Society position paper tells us about HRT and breast cancer risk. This paper was published last year. So here we can read that there is no additive effect of an underlying breast cancer risk and hormone therapy use on breast cancer incidence. And the underlying breast cancer risk factors that are addressed here are age, family history, genetic risk, or even benign breast disease or personal breast cancer risk factors like obesity. Secondly, there is some observational data out there that micronized progesterone and dihydrogesterone may have a lesser association with breast cancer in comparison with synthetic progestogens. Finally, for breast cancer risk, it doesn't matter how you are using estrogens. If you take them orally or transdermally, it doesn't matter. This topic is only important for cardiovascular risk discussion. And finally, there is some data out, as I've already said, that the combination of estrogens with the SERM basodoxifene seems to be breast friendlier than the combination of estrogens and specifically synthetic progestogens. So again, what can we offer to Betty? Because she's really suffering from hot flushes, but we could convince her with the NAMS position paper. So now we can offer a standard dose estrogens. I would choose standard dose here because she has severe hot flushes, and we can either combine it with a sequentially combination with progesterone, or again, a levonorgestrel intrauterine device. She doesn't have any major cardiovascular disease risk factors, so she can choose if she wants to use an oral or a transdermal estrogen. And we can either choose, for example, a fixed combination like Femostone 210, or we can also freely combine hormones. So we can use a transdermal estradiol, an oral estradiol, and we can combine it with dihydrogesterone or micronized progesterone, either sequentially, or we could also offer, again, the levonorgestrel intrauterine device. So I come to my conclusion. First of all, the term progestogen is the umbrella term for synthetic progestins and micronized progesterone. So as you have seen, most women will need various progestogens while they pass through different reproductive life stages. Synthetic progestins are best for contraception and abnormal uterine bleeding, for example, while dihydrogesterone and micronized progesterone, they do not inhibit ovulation. So oral micronized progesterone has a sedative, antidepressant, and anxiolytic effect. However, some women do not like oral progesterone. And in these cases, we can choose dihydrogesterone because dihydrogesterone does not have central nervous effects. So this is somehow the preferred progestin in women who do not tolerate progestogens. And finally, dihydrogesterone and micronized progesterone are more breast-friendly and vessel-friendly. So they are the preferred progestogens in older women or in women with cardiovascular comorbidities. Thank you very much.
Thank you very much, Petra. I think it's a fantastic lecture, that one who opened the other part of the use of progesterone and progestogen, which is the part when menstrual cyclicity start to changing around menopause, and going on, we achieve the menopause. Then, dear friends, we had two fantastic talk, one related to the progesterone use and progesterone use in pregnancy. Progesterone means progestation, and this is how Professor Carp, and then the other lecture of Petra, how progesterone can be used and protective of human health in period to transition to the menopause and also after the menopause. Now we have the time for the discussion. We have received a huge series of questions. I will make question and asking short answer because we have 15 minutes to close the session. And then I will invite the two speakers, and then I will make the question to both of them, going from one to the other one. Okay, starting to the question to Howard. We have several questions which are related to the use and the preference between micronized or progesterone by oral way or by vaginal way in treated abortion and in pregnancy. Can you give your final comment on that point?
But whether to use micronized orally or vaginally. The problem with oral micronized progesterone is that it becomes denatured in the liver and the metabolites have no progestogenic effect. That is why a method was found to make progesterone absorbed. And that was why it was micronized, so that it would be absorbed across the vaginal epithelium. Therefore, the accepted way of giving micronized progesterone is mainly vaginally rather than orally.
Yes, thank you very much. And then now I will go to Petra, Professor Stute. Thank you. And we have a question. A question is related to some symptoms. This is from Asma Basha, which is a general question. It's related to the spotting event under hormone therapy in menopausal transition and in menopause. And if a woman should have a spotting while on Femostone 210, what is your action? What is your strategy to try to protect from spotting under this kind of treatments?
Okay, so first of all, I think it's important before you start any hormone replacement therapy that you do a gynecological examination, including transvaginal ultrasound, although it's not officially indicated, but just to be sure that there's no pathology in the uterus. So that's the first step. And then if you start, as you just mentioned, a sequential hormone replacement therapy, then it's often possible that at the beginning of the treatment that you may have some spotting. So that's, if it's not a chaos, I would just wait until after 3 months to see how the menstrual cycle developed. On the other hand, because femostone 210 is not inhibiting ovulation, it's possible that it's not completely synchronized with the individual cycle. So in this case, it might be better if you choose like an oral combined contraception with estradiol to be sure that you suppress the ovulation, and then you will have a more stable menstrual cycle. But most importantly, it's necessary to rule out any pathology.
Thank you very much. And then now a question. I put the question together. I thank all those who have put questions. I don't read all your names because I try to put together questions. There are some interesting questions, about to the beginning of use of progestogen supplementation in pregnancy. And the question is, it will be better to start waiting symptoms, negative symptoms, or better to start in any case since the beginning of since the beginning of pregnancy, even though without symptoms?
Yes, I think it is different in threatened and recurrent miscarriage, because a patient with threatened miscarriages may be her first pregnancy. There is no need to give anything in the first pregnancy if there are no problems. Therefore, in threatened miscarriage, you would start progestogen when she has symptoms. However, in recurrent miscarriage, she has already had a number of pregnancy losses. So in those patients, I would want to give it prophylactically, and I would start with progestogen support the moment the beta-HCG pregnancy test becomes positive.
Thank you very much. And then a question to Petra, arising from several questions related to the possible fertility in menopausal transition. If the pregnancy have to be avoided, then then your suggestion will be in any case to use one of these techniques who provide also contraceptive effect in addition to progesterone protection.
Yes, so if contraception is also needed, then it's important that we choose something which is officially also approved for contraception. So this would be, for example, an levonorgestrel intrauterine device, which you can then combine with estrogens if needed, or you give a progestin-only pill, or if there are no contraindications, you could also give combined oral contraceptives with estradiol, so either Clyra, Zoeli, or Drovelis in this age group.
Thank you very much. And then now a question, Howard, from Sergio Brantes. And then he asked, the question is related to the dose. The dose of micronized progesterone can be used in recurrent abortion. And do you have any specific dose that you suggest, or these have to be adapted to the patient?
In a way, they have to be adapted. The problem is there has never been a dose-finding study, not with micronized progesterone and not with dydrogesterone. Everything has been done on an empirical basis. With dydrogesterone, the first standard doses which were used around about 40 years ago was to start with a loading dose of 40 milligrams and then to go down to 20 milligrams. Since the Lotus studies looking at dydrogesterone support in IVF for luteal support, they used a 30 milligram dose. As I've mentioned, there are papers that have used 40 milligram doses, particularly if the patient has a heavy bleed. I would use 40 milligrams, but it is somewhat empirical. With regard to micronized progesterone, there is also no standard dose. people have used 200 milligrams, 400, 600 milligrams. In the Promise trial, they used 800 milligrams, and they did not show an effect. Now, there may be an effect, an additional effect from higher doses. I don't know. It's never been reported. It's never been studied. So it is really empirical. But I would use 30 of dydrogesterone, 600 of micronized. They seem to be about equivalent.
Thank you very much. And then now, Petra, a question which is, I will double two questions. One is sequential or continuous progesterone regimen for HRT is safer for breast cancer? And I would like also add another question. After 10 years of treatment, Vilma, she feel very well. And then, but when she stopped, the symptoms rise again. What is your strategy?
Okay. So for the first question, what was it? Say it again. Micronized, say it again, please.
Micronized sequential or continuous progesterone regimen for HRT is, what is the
breast cancer.
For breast cancer, yes.
So in general, there are some cohort studies there showing that sequential HRT is breast friendlier than continuously combined HRT. However, this has not been proven in randomized controlled trials. So I would decide on the regimen depending on the reproductive stage the woman is in, and also if she wants to have a menstrual cycle or not. The second question, if someone has HRT for 10 years and wants or tries to stop it and the symptoms are coming back, then I would discuss restarting the HRT depending if the woman wants to get rid of the symptoms. So there's no upper limit for HRT duration.
Thank you very much. And then now another question we are approaching to the last question. And then for Howard, okay, there is a question from Maria Portale speaking about, do you think that could be the difference in progestogen effect in pregnancy at the level of progesterone receptor? There is any idea?
Yes, there are some ideas on that. The thing is, it's not so easy to see the progesterone receptor. There is some work from Schindler of Germany in which they suggested that that dydrogesterone, in fact, has an enhanced effect and that it binds the progesterone receptor 50% more than progesterone itself. There has been other work on other progestogens on receptor binding. Because of the receptor binding, that's the reason that the administered dose is so different. You know, with dydrogesterone, you talk about a 30 milligram dose, as I did a few minutes ago, and 600 with micronized progesterone. So there is something going on at some other level that the doses are so different when you speak in terms of milligrams. Receptor binding, bioavailability, other factors will come into play. And of course, denaturation in the liver.
Thank you very much. And then now one question for Petra from Daniela De Feo, which is a general question related to the impact of menopause therapy and what to do and how to manage. Daniela, she asked, considering the huge positive effect of hormone therapy for the majority of postmenopausal women, why is still considered by common opinion and women to a not effective and not necessary treatment? In Italy, for example, the percentage of postmenopausal women in hormone therapy is really so poor, although the chronic degenerative diseases are extremely high in the female population after 65. What you suggest us to do for making women more aware of hormone therapy benefit?
Yes, that's a tricky question. I absolutely agree. There's a huge gap between our scientific world and the world outside the science, and it's very hard to always present the positive effects of HRT if the media is so much dominated by the breast cancer risk over and over again. So I think we can only work on it like we are doing right now, and also go to the media and so that we somehow reach the women.
Thank you very much, Petra. And then now is my final question to Howard and my final to Petra. To Howard. Howard, certainly we have another problem. Now the pregnancies start very late in the fertile life in women. It's not that it was in the biblical times when the pregnancy arises just after adolescence. Now they are mostly asking about pregnancy in menopausal transition. Then at that time, do you believe that progestogen treatment, in any case, since the moment of the beginning of pregnancy, can have any positive effect in a woman who she never experienced an abortion because she never had any other pregnancy, but she started a pregnancy over 42, 43 years?
First of all, I don't really have an answer on that. I just say, when you say in biblical times, remember, Sarah, Abraham's wife, was said to be 90 years old when she became pregnant the first time. So I'm not sure about biblical times. But anyway, if we continue from then, if you have a woman who is in her mid-40s or late 40s and she becomes pregnant for the first time, many of those pregnancies will be by assisted reproductive technology. And it will depend whether you have a corpus luteum or do not have a corpus luteum. If there's an egg donation cycle and there's no corpus luteum, then yes, the woman needs progestogen support. If there is a corpus luteum, then it will be difficult to say. But again, if there's assisted reproductive technology, I would give progestogen support in order to make sure that that corpus luteum has a little extra help. If the patient becomes pregnant spontaneously in the menopausal transition, well, I'm not sure that you need to add anything at all on a strict medical or scientific basis. However, if the patient says, this is my first pregnancy, I'm 45 years old, I want to make every effort, in some things we don't have evidence. We have to go by patients' wishes.
Thanks. And then now, Petra, you spoke about also all those studies showing that if we need, in addition to an estrogen, because you have the uterus, also some progestogen. Certainly in nature, progesterone or detrogesterone have shown that they have less negative, if no positive effect on cardiovascular tissue, and also less risk to increase the number of expected breast cancer. Then in your vision for the future in women who ask to be treated also for longer time, what is your general suggestion that you give to this kind of patient, taking in mind the observation that I was mentioning?
Okay, so you're asking if I would just recommend to take it forever?
Yes, and with what?
Okay, I think we are with the data we have on estrogens in combination with micronized progesterone and dydrogesterone, we feel quite safe. But of course, we have to discuss the pros and cons on a.
Oh, we have lost your voice.
And the con is only the breast cancer risk if we decide to use estrogens transdermally. So if a woman goes to a regular breast checkup and she doesn't have any other severe diseases and she wants it, I continue.
Thank you very much. Thank you, dear friend. It was a fantastic webinar showing and on a very hot topic. What kind of molecules, for what kind of duration, what kind of biological situation we can face and improve the women's health by the addition of a proper progestogen, reminding that progesterone was created by God for women and detrogesterone is absolutely very similar, but they have no some effects, and mostly don't interact with gonadotropin production, and they have no effect on your human brain. Then, with all of that, I would like to thank Petra, ladies first, and Howard for your generous presence today and the beautifulness of this webinar. And then I thank all our participants. We are still more than 350. And I would like to remind to all of you that we will have the International Society of Gynecological Endocrinology Congress in May 2024. And in the meantime, we will have a series of webinars, such today, on most important topic of our discipline. Thank you for being with us. Enjoy your life. Take care. Take care also to the COVID presence, and all my compliments to our fantastic speaker. Thank you, Petra. Thank you, Howard.
Thank you very much. Bye-bye.
Bye-bye.
Okay.
Enjoy.
Thank you all for listening. Thank you. Ciao. Goodbye.